I brought all these baby skulls. These are all patients, actually. I'm going to single out Dr. Covarrubias. He referred me my first cranial wall surgery that I did in El Paso. So I'm very grateful. And I think his patient's skull is up there. But anyway, we get these 3D printed. I'm going to talk, there's syndromic and there's non-syndromic. So what does that mean? So non-syndromic craniosynostosis means that it's not associated with the syndrome, right? So syndrome means there's multiple things involved going on with this kid. The syndromic cases usually involve multiple sutures of the skull versus non-syndromic cases, they really usually only involve one suture of the skull, okay? I'm going to get the skull pulled. So, and actually, I have a picture of one here, don't I? So, this is a skull, and there's these squiggly lines, which y'all are all very familiar with. This is the sagittal suture, okay? Sagittal suture. This is the coronal suture, that's in the front. And this is the lambdoid, which is in the back. And y'all all know about anterior and posterior fontanelles, right? That big area that's not closed in babies, which is right here. And then there's a big area back here in the back also that is not closed initially, and that's called the posterior fontanelle. So as adults, if I were to die and y'all were to see my skull, it would look somewhat like this, except a little bigger, okay? I'd have all these squiggly lines, and what those are cranial sutures. And these are super important when it comes to babies, because babies come out, and you know how babies' heads can look abnormal when they come out of the vaginal canal or after a C-section, right? So they have these cone heads, and our bodies were uniquely designed to be able to come through a birth canal, have all of this completely kind of deformed, and then pop back out and kind of normalize, right? So how does it do that? Well, it does that because of these sutures. So these sutures in babies are wide open. And that's why when you look at babies' heads, you can see that there's like a little ridging, there's like this, you can press this side moves, this side moves, it's great. You know, but then in an adult, I mean, you know, this isn't going anywhere. So basically, these sutures are wide open, and in the first really the first 3 to 4 years of life, our brain grows rapidly, okay? And these open sutures and that open fontanelle, they allow the brain and the skull to grow in all directions, okay? And so that's why a baby's head looks so big. It's because it is that big. And that's the first thing to grow to full adult size is the baby head. And by the age of 5, like we're 90 to 95% completely grown for our head. So that is why these sutures are important. And what I'm going to talk to you about today is what happens when these sutures fuse prematurely. And some bad things happen, unfortunately. So one thing that'll happen. So yeah, so here I list some bullet points. 80%, your cranium is 80% of the adult size at birth. It's pretty much definitive at age 3. Fontanelles are open. The back, it's normal for it to close between 3 and 6 months. Don't worry about that. In the front, it's normal for it to close between 9 and 12 months. It's okay if you can't feel it then. And don't be afraid to press hard on a baby's skull, okay, to see if you can feel it. You're not going to hurt them. So when it comes to skull fusion, you know, I told you either it's syndromic or non-syndromic. Well, 85% of the cases are non-syndromic. Like this baby. This is like the one, actually, that I was initially saying. So does his head look a little different? Okay, looks kind of long, right? So this baby has something called sagittal suture. I'm totally getting ahead of myself. Sagittal suture synostosis. So this suture of the skull is fused. Now, these are open. So the baby's head can grow, but only like this. So they end up with this horrible deformation, and the head cannot grow any wider than you see it right now, okay? So you can imagine, as an adult, this is going to look really strange, because that brain is going to continue growing in this direction and in this direction, but it will not get any wider in this direction. This is called sagittal suture synostosis. And I'm going to talk a little bit more about that in a minute, and about why it's dangerous and about why we correct it. I want to tell you, why does this happen? This is one thing that everyone always asks me. And the true answer to this question is we don't really know. It's like cleft lip and palate, and it's likely multifactorial. Okay? We do know that there are some genes associated with it, like the FGFR, FGFR1, 2, 3, but these are usually in syndromic patients with Apert syndrome or Crouzon syndrome, where they have multiple sutures fused. For the single syndromic or single non-syndromic suture fusion, it does seem to run in families a little bit, just like cleft lip and palate, right? If I had a cleft lip and palate, the chance of my kid having cleft lip and palate is only like 3 to 5%, and it's the same with this. So we don't really know why. We do know that certain genes will cause it to happen, but we're not entirely sure. So there's 3 different kind of theories. One is intrinsic bone malformation, which we know it can be related to metabolic, pharmaceutical injuries during pregnancy, and then also fetal head constraint. Some people think, if you have intrauterine growth restriction, you can end up with a higher chance of having a baby with synostosis, which somewhat makes sense too. And then a primary brain malformation. And you do see this. So kids that have a primary brain malformation, their brain just isn't going to grow. Well, their sutures, if they're not used, they just fuse. So why do we do surgery? So these are the reasons we do surgery. One, we know that craniosynostosis is associated with developmental delay, both mental and motor. It also is associated with an increase in intracranial pressure. So now, non-syndromic, one suture, depending on what suture it is, can be, like sagittal sutures, about 25%. Although there was a recent study that came out that actually said about 43%. So, but 20 to 43% will have an increase in intracranial pressure. Now, an increase in intracranial pressure is pressure on the brain. Pressure on the brain can cause papilledema, which can lead to blindness, and it can even cause death by herniation. Now, most of the time, the non-syndromic kids with one suture, it will not get that bad. But the idea is that they do have these developmental delays, they do have these motor delays, and we don't know which ones will have the increase in the pressure on the brain without actually sticking a device into the skull. So if there's a 25% chance that this kid's going to have an increase in intracranial pressure, usually we just go ahead and operate. And I think it makes sense. If it were my son, they would have the surgery. Papilledema, and I'm just going to tell you all this because a lot of people are under the impression you send them to an ophthalmologist and they can look at their eyes, and if their optic nerve is atrophied, and that's called papilledema, right? There's pressure on the optic nerve. That tells you whether or not there's pressure on the brain. And that's true in patients that are over the age of 8. But unfortunately, in babies, when we have to make this decision, it doesn't really tell us. It's only like it's bad. It's like 10 to 15% sensitive for detecting a raise in intracranial pressure in a small child. So yeah, restriction of cerebral growth, visual impairments, and then there's psychosocial issues. Some of this is for cosmetics, I will say. This suture synostosis right here is called netopic, which is right here, okay? So these kids get what's called Craniofacial, which means a triangle head, and it looks like a triangle. And so this one, the good news is the least associated with a raise in intracranial pressure. But a lot of these parents want an operation, and it's primarily cosmetic. And the reason is their head is pointed right here. I mean, it comes to a point. And so, the idea of going through kindergarten and then middle school like this is not super appealing. And also, they don't have good protection of their globes and with this kind of deformity. So that can lead to blindness, and they can get hit by balls in the face, and it can cause issues. So this is a little kid. He had sagittal suture synostosis. which is 40 to 60% of the babies with single suture non-syndromic synostosis. You can see them. I took out a lot of the bloody pictures, but I left some. So this is kind of what we do. So, and I included the CT scan. This is the lambdoid suture. This is the coronal suture. And look, there's not a squiggly line here. So this kid has sagittal suture synostosis. So what do? We take out that bad suture. Now this is crazy. This just shows you the regenerative capacity of babies. You can actually take off their entire skull and it will regrow when they are first out. But we don't do that because this is a very dangerous surgery, okay? And also you get a better cosmetic and functional result if you leave a lot of the bone. But see, we've done what's called barrel staving, where we basically allow the brain now, we create sutures so that the brain can grow as it wants. And we actually, in this child, he was young, so he was 6 or 7 months. So we left all of this open, and this completely covers with bone. Versus if you or I get in a car accident and I get a hole the size of my thumb in my cranium, it probably won't close with bone. So that's incredible, you know. Now this is metopic suture synostosis. This is the one I'm talking about right here. This accounts for 27% of non-syndromic synostosis. Now, this is the only suture that's allowed to close in a kid. All the others need to stay open their entire childhood. But this closes naturally between 2 and 8 months of age. So if their head is looking severe, I definitely recommend sending them over to see me. But if you notice just a little bit of ridging and their head is not super severe as far as triangle shaped, then you can still send them over to see me if you'd like. It's just for reassurance for the parents. But generally, there's nothing to do. It's somewhat normal for this suture to close in the first year of life. So this is before and after. And this kid, I saw his 1-year follow-up in my office today, which is kind of cool. So he's doing great. He's got long curly hair. You can't even see his scar anymore. He looks awesome. He kept giving me a high five. He hugged me. My own kids won't even do that. So anyway, I bribe him with chocolate. So you can see, here's the triangle, and here it is, overcorrected. We make him like a basketball, okay? And there he is. That's 1 week after surgery. That's 1 week after surgery, his head looks like a basketball. And the reason we make them so wide is, one, we want to give that brain plenty of room. But the other reason is that we know that all the soft tissues are going to try to pull that back to where it was. So we overcorrect it, and then they kind of normalize. So I saw today, his head looked great. It wasn't quite this big, which saddened me, but it still looked awesome. So this is another one. This is a unilateral coronal synostosis. This is a really cool one. So this is the coronal suture. I'm going to talk about this girl. This is a really interesting one too. But this is the coronal suture right here. Now this is after the operation. So I plan the surgeries online, right? Like with a virtual surgical planner. And then they give me pre-op skull and a post-op skull. So this is post-op skull. And then I have guides that guide me during surgery where I can get it exactly where I wanted it. But the coronal suture is naturally here. This girl right here had 1/2. It's called a unilateral coronal suture synostosis. Okay? So let's just take a poll. This will be fun. So who thinks it's the right side that's affected? Raise your hand. Okay, Amy, thank you for participating. Yeah. Who thinks it's the left side? Okay, so it's the right side. Now, I should say there might be some confusion here. This is her right that I'm talking about, right? Okay. So maybe y'all were thinking screen. Give you the benefit of the doubt. So this patient came to me, and the concern was for the left side, and I get this all the time. They're like, her eye looks awesome on the right, it's wide open. And they thought she had some kind of eyelid ptosis. She was referred to me for eyelid ptosis, which, you know what? I applaud the person who sent them to me. You noticed something was wrong, and you sent them. And so, but really what I explained to the mom, I'm like, it's not that this eyelid is abnormal. It's actually that the skull is fused up here, so the forehead cannot grow here. So the forehead grows here, so that you have a normal forehead here. This forehead on this side is flat. And that flatness pulls the eye up. And this is called the Harlequin eye deformity. Okay, I'm sure it got its name like 100 years ago. But that was the whole idea, this eye was up. So in here, I don't know, this is the skull. This is the normal suture. There's not any suture on that side. So this is what we do, and we do this. This is the virtual surgical planning I use. Okay, now this one is crazy. This is called Pansystolicosis. This is like a 1 in a million. And this is one of the first cases I saw when I got here to El Paso. I'm like, where have I come? No, this is rare. This kid, and this is a true emergency, okay? Does anyone see any suture on this kid's head? No, there's none. There is no suture on this kid's head. And this is, he was appropriately named Santos. He's a super cute kid. He's been in and out of our hospital a lot. He's won over everyone's heart. They did a little news special on him. This will kill you quickly.
It goes after birth.
Did the which? Yes. Yeah, no, so that's a good point. So this is one of the, if you see a pansystotic baby, you need to be thinking of thyroid disorders. You need to be thinking of a whole bunch of different things. So he actually came to me from our endocrinologist here at Dr. Granados. I'm blanking on his name. So Dr. Granados was like, listen, I keep taking like measurements of this kid's head, and he's small for age, so I have him on growth hormone, but his head is staying the same size. So completely fell off the growth curve. He's like, could you just take a look? And this is the trickiest one for all of us, okay? Because this kid comes into your office, and his head doesn't look like a triangle. His head doesn't look like, like this. His head looks like a normal head. And the reason his head looks like a normal head is because every single suture is fused. It's just a little micro head, right? It's just a little small. So we get a CT scan, and the CT scan shows us that there is no open suture. So his brain is rapidly growing right now, right? Because he's a kid. So where's the brain going to grow? It grows down, and he herniates his brainstem, and he dies. No, fortunately he didn't die. So we operated on him. Yeah, so he presented late, Yeah, he presented at 18 months to me, which is late, Usually they present much earlier, so I was very concerned. And also, 18 months, that's not like 9 months. You can't take off as much of the skull and expect the skull to grow back. So you have to think a little outside the box. So we did something called distraction, which Dr. Brooke was telling you about for the maxilla. This is like the coolest thing ever, right? So you put these distractors on, and they stick outside the skin. He called him his ganchos. Actually, his mom called him his ganchos, which means, horns in Spanish. So they stick outside the skin, and every day I turn those 1 millimeter. Yeah, just like a little ratchet. I give them a screwdriver, and I'm like, turn it. And they turn it, and it grows 1 millimeter a day. And look, we grew that thing 30 millimeters. So there's us putting it on. Now, I included this picture. So when we took off the cranium, that is the imprint of his brain on the skull. You should not have your brain imprinted on your skull, okay? This means that there was significant pressure in this little kid's head. This kid wasn't able to walk. He was severely developmentally delayed. He had a whole bunch of issues. So we did this surgery, and these are the distractors in place, okay? And there he is, 25 days after distraction. He's like the cutest kid in the world. And it doesn't hurt that much. You would think it would. It doesn't. So then I went in and I took the distractors off. So I brought his skull. So 18 months, that's what his head looked like. Okay, it's small. Way less than a 2 percentile. He was like, this is what it looked like on the CT scan after the distraction. Now, you see all this open, but you see actually, remember, this is only 3 months later. It takes bone like 6 months to form. So look, he already has bone forming, but really he already actually had all the bone there. It just doesn't show up on the CT scan. So, and then, unfortunately, but in a good way too, you have to do a second surgery on these kids, right? Because you have to get the skull. His skull's not growing at all. So I have to get his skull as big as I possibly can get his skull. So then we do the front, okay? And that's what he looked like after the front. So you can see how much we increased his skull by 4 centimeters. And on the last surgery, I could barely get the skin closed. So there he is. He's looking great.
You said that Dr. Granados was treating with like human growth hormone. Did he have any other metabolic issues?
So he didn't. And initially he did, actually. And you know what? I'm sorry, I'm not going to be able to tell you. But actually, I think he was hypothyroid. But he was a NICU baby for a long time. Y'all probably recognize him. And then and then that happened. He had one suture. I lied. He did have one suture open. But it was the lambdoid. This is the only suture. But that's a pretty unusual case. Now, I thought, since we're talking about weird head shapes, I wanted to talk about plagiocephaly, okay? Because the majority of what everyone's going to see is not the synostosis. The majority of what you're going to see is, you're like, oh, that baby's head looks a little weird, a little asymmetric, okay? So I thought it would be good to talk about what the asymmetries mean. So, y'all are all familiar with, do we have any physical therapists or occupational therapists in the room? Okay, great. So they're very familiar with torticollis, very familiar with plagiocephaly. And what ends up happening in these babies, and pediatricians too know, you end up getting a tight sternocleidomastoid, or maybe the parents, not any fault of their own, but the baby has to go to daycare almost immediately after birth. Well, and the daycare that they send the baby to isn't really holding the baby. That baby just lays there flat. And so wherever that baby's head is laying, and wherever the pressure is going to flatten out. And we know already that the brain is rapidly growing during this stage of life, right? So the brain's going to grow anywhere it can. And it's going to grow where there's no pressure against it, which is everywhere except where that baby is laying. Okay? So if that baby's laying here, this part of the head's going to be flat. This ear, it's amazing. The whole ear moves forward, and then bossing happens here. So it's like the baby has a parallelogram-shaped head. See? Flat here, ear moves forward, bossing here. It can even affect how their jaw looks. So in severe cases, you just get this horrible flattening. Versus a synostosis of the lambdoid, it actually is more of a trapezoid appearance. I wanted to include a couple babies. So look, this baby, look at where the ear is compared to this side. Look at where the flatness is. Look at how the head kind of goes out a little bit more here too. This is a super abnormal shaped skull. But this is not due to an intrinsic abnormality of the bone. This is due to positional laying of the child. The unfortunate thing is once they reach about 1 year or 2 years of age, there's almost nothing we can do. So if you notice this, rapid recognition of this is important. So you see this on a 4-month-old, it was very embarrassing. 2 of my 3 kids so far have had plagiocephaly. And, we caught it early, and they both rounded out great. And most babies now, because it's the Back to Sleep campaign, right? We don't put babies on their bellies because we're afraid of what might happen. So we put them on their backs, and that's appropriate. But this happens when they're put on their backs. So you just have to, a lot of babies are going to get plagiocephaly, and those especially between like 1 to 4 months. But at 4 months, when they can start sitting in a bumbo chair, or they can start sitting in a Johnny jumper, or they can start doing more tummy time, it is vital that you get them doing that, because otherwise they'll end up with this. Now, does this affect their brain? No. This is just cosmetic, but you hate to have it if you don't need it, right? And then I'm going to briefly address helmet therapy too, okay? So a lot of people wonder about helmet therapy, and there's actually some great prosthetists here in town. Helmets in the most recent randomized, and there's been a couple randomized controlled trials that have looked at helmet therapy where you put helmets, which the idea makes sense, right? You put pressure here, this is wide open, so their brain grows this way. And it works. But here's the deal. They cost about $2,500. A lot of insurances don't cover them. And in the largest and best studies we have, they show equal efficacy with non-helmet therapy. So it's hard to justify doing a helmet. However, I will tell you, with NICU babies, if they're bad, I'll do it. If it's a torticollis baby, I do it. Because, you know, I don't want them to work through their PT for the whole year before getting a helmet. But if they're a severe torticollis baby, I'll send them. If they're a handicapped child, or they just have poor muscle tone, and their head is super flat, like this, I will do it, okay? So, anyway, kind of interesting. So now we're going to talk about syndromic craniosynostosis. So we only have 11 minutes, and I am dedicated to getting y'all out of here on time. I'm going to briefly talk about Apert syndrome. Maybe not. So Apert's and Crouzon syndrome, what is that? That's this. Look at how big this head is. This is like macrocephaly. This kid was originally seen at a year of age, but was recommended to not have surgery. They had bicoronal synostosis. So both coronal sutures were fused. So the reason we do these surgeries, as I said, is that we know that if we don't do them, bad things will happen. Even though maybe at that moment when the baby's being evaluated at 1 year of age, they look fine. Well, at 4 years of age, this actually came to me from our pediatric ophthalmologist, Dr. Radovich. She was like, listen, I have this baby, and the baby has a whole bunch of papilledema. And the eyes look terrible. So I'm really concerned about the status of this baby's brain. So she sent the baby over, and this baby had a huge forehead and looked exactly like this. Okay? I call it the bang sign. All of the kids with bilateral coronal synostosis who come to me late, they all have bangs like that. And it's because their forehead is this tall. So moms just put bangs on them, and they look pretty good. You know, you get a nice like curl in there, you get a nice curve. So unfortunately, you know, this can cause major issues. And now I'm operating on this baby when they're 4. That's too late because it's such a bigger surgery for them at that point. But listen, this girl did great. This girl had Aperts. So what's the difference between Aperts and Crouzons? Does anyone know? Okay, I'll tell you. So Aperts, they have syndactyly. So look at those hands and those feet. Everything's fused. They have the exact same mid-face hypoplasia, and I wanted to show you this on this girl. Look at how you can see her eyes like this, right? So she had mid-face hypoplasia that was pretty severe. This is super vulnerable for your eyes. There's a kid, and I'll get to him later actually, where in his orphanage that he lived in, a kid went blind completely because he never had surgery. Because his eyes were just sticking out there, and after multiple balls being thrown and trauma to his eyes, he went blind from trauma. It's just terrible. So anyway, so for this kid, we needed to move her whole face forward. So we did something called this is called a monoblock, where we actually move the forehead, the orbits, the maxilla, and we move the whole thing forward at one time. And we also move the anterior cranium. So here we are. I used cadaver, this is cadaver fibula actually, that we put in here. Do you have a question? Oh, okay. So look at that forehead. That's what I'm talking about right there. So here she is post-op. Looks pretty good. She did great. So this kind of goes back to team. These kids have hearing issues. They have breathing issues. They have IQ issues. They have, I mean, it takes all of us. And I'll tell you, as a surgeon, you know, we're terrible. We skip everything else. You know, we're like, what surgeries do they need?
But these kids, that's the great thing about the team. You need this complete evaluation of these kids to catch these things. And we get in these rooms and, you know, I'm like, oh, the kids seem so happy. And the social worker is like, yeah, they were suicidal and I think we need to do that. And I'm like, really? I mean, I just don't understand. You know, so it is the best thing we can do for these kids is to see them in these team environments. I'm really proud of El Paso Children's Hospital. You know, the craniofacial team there, they've really been really pushing toward the national credentialing, and we've made really good progress. So the cleft team is nationally certified, and the craniofacial team in the next couple months will be too. So it's pretty exciting. I'm going to skip a lot of this because we only have 7 minutes left, and I want to get you to some more pictures. This is a Treacher Collins kid, and they just have this very characteristic deformity. They have no zygomas. It's like hemifacial microsomia that we learned about earlier today almost, but on both sides. Okay, it's a little different, but more or less the same. We reconstructed her with ribs. I want to go to this picture too. So I saw this patient today too, actually. She came in for her follow-up, and we didn't do a lot of her surgeries, but I did her rhinoplasty, okay? She came in for all she wanted. I'm like, Karen, you know, and she's giving me permission to use her name. Like, Karen, you know, there's a lot I think we could help you out with. We can do implants here. We can do this here. She's like, no. And Dr. Burke, I should say, she came to him. She had multiple operations in Dallas where, unfortunately, they had resulted in a fusion of her mandible to her skull. So she could not open her mouth at all. And Dr. Burke put bilateral total joints in her, and now she can open and close her mouth and eat. So she loves Dr. Burke. Every time she comes in the office, she looks at him, brings him chocolate. She started bringing me chocolate too, which was nice. So look, this is her nose. This was the hardest rhinoplasty I ever did, and that's her before and her after. Okay, to me, you know, I was satisfied just because it was so hard and the anatomy was so deformed. But this is not how I would have liked the rhinoplasty to end up, right? I always ask, because I'm doing a study, I ask all of my patients before and after how they feel about their nose on a scale of 0 to 10. I ask them for breathing, and I ask them for cosmetics. And for cosmetics, like in this case, I was like, so, you know, 0 is basically you had no nose, and 10 is you have the most beautiful nose in the entire world. And so she told me, she's like, well, before the surgery, she's like, my nose was a total 0. She's like, and now it's a 10. You know? And like, I don't know, it like kills me. You know, it's all about perspective. So this is what the Wonder Kid had, by the way, if y'all were wondering. It's the Treacher Collins Syndrome. Hemifacial microsomia, we're not going to talk about this because we already have. This is the kid that I picked up. His diagnosis. Look at how he's sticking his tongue straight out, but it goes to the right. These are the box osteotomies where we move the eyes closer together. I want to get that. Okay, this is just, I wanted to talk about, so how I recommended I talk about kind of long-term sequelae. So I did want to get to this section. This guy comes into my office. You know, he's a little bit older than me. I did not do his original work. You know, I asked him, it's important to pay attention to chief complaint, okay? And what was his chief complaint? Anyone want to take a guess? He can't eat, okay? He had a denture that was made, but if you look at the side, he's not wearing his denture. When he wears his denture, his upper lip goes all the way up over his nose. And now his denture doesn't fit anymore. All this guy cared about was his teeth. And I had to remind myself, sometimes it's better not to be a hero. Because I wanted to do a ton of things to help this guy, right? That I thought would help this guy. But really, what this guy wants is to chew food. And so that's what we did. We gave him implants. We also do this using virtual surgical planning. We did bone grafts. We added bone graft into his maxillary sinus. We got him some good implants. And then, I don't have his final pictures here, unfortunately, but basically, now he'll have something stable that he can rip into steak with. And that's all he wants. Yeah, exactly. And then psychological. This is a big deal. The psychological sequela for these kids, and I'm skipping over it just because I don't have a good story for it. But it is a big deal. All of these kids struggle with it. They all go to school, and they're mocked, and they're teased, and everyone asks questions. And it's a huge component. Speech. This kid, great-looking kid, had a good cleft lip repair. This was before his rhinoplasty. And when he would talk, you could not understand one word he said. So we did a pharyngeal flap, and we were able to achieve that. But speech is a major issue for the cleft lip and palate population. Persistent infections. This kid, I love to tell the story of this kid. He flew up to me. I have 2 more minutes. I'm almost done. He flew from Peru, and this kid had Crouzon Syndrome, but it was mild. So but his mandible was pretty far back. So he could not eat without aspirating. Okay? So he ended up in the hospital every month with pneumonia. And so he had severe OSA. So we did a distraction, which y'all have heard tons about distraction now. Probably no more than most of the world. On his mandible. And we moved his mandible forward. We put that on there. And then here he is, just post-op 1 year. Hearing. You can't speak without being able to hear. And breathing. And I'm going to end with this story. So this kid actually came to us from Romania. And he had Crouzon Syndrome. So what's the difference between aprids and Crouzons? Right. So look, he doesn't have syndactyly. He's a Crouzons. This is him. And it was his buddy who was blind in the same orphanage. His parents dropped him off in the orphanage because he had 5 siblings and they couldn't take care of his medical needs. So they, at the age of like 7, dropped him off in this orphanage. He had a severe inability to breathe. So the guy who brought him over actually wasn't his. This guy worked in the orphanage. He was an anesthesiologist who volunteered his time in this Romanian orphanage. And he would just come, and he came to us because we went to Romania on a mission trip. And he stopped me in the hospital, and he's like, "Can you help this kid?" And I'm like, "Well, probably not here. We'd have to come to the U.S." And so he came to the U.S., he came with him, and he stayed with him and basically acted like his dad. And he's like, he can't breathe at all. So at night, I went ahead and I put pulse ox on him. And he would desat every 5 minutes to 55. And then he'd arouse and breathe. I recorded it. I was like, this is crazy. So he needed that midface. See how far back that midface is? Everyone thinks it's the mandible that's associated with sleep apnea. Actually, in studies, if you pull the midface forward, it makes more of a difference than pulling the mandible forward. But obviously, if a kid has no mandible, it's the mandible, right? So it depends on what's going on. But don't discount the midface. That matters. And look at his eyes. See how you can see all that sclera? Just the white part of his eyes underneath. So we did a LaFord 3. This is where we moved and I took the video out because it was just so graphic. But this is where we take the face apart from the cranial base and we move it forward. And we moved him forward 15 millimeters. And that's him before and after. And, I lost touch with him, unfortunately. So this was a few years ago now. But they had told me that he was going to be able to be reunited with his parents from the orphanage now that he was able to breathe at night. So anyway, he was super excited about that. Anyway, in summary, there are a lot of these kids in our community. And there are a lot of these kids that come over late for us from Juarez and from Mexico. And I just, more than anything, I want y'all to know that we have the resources here. And we do I have a policy in my office, the first visit for these kids is free. I don't charge them anything. It's just to sit down, talk with the parents, and let them know. because a lot of times financial needs are a barrier for these kids. And so, but usually if we get them into our office, we can connect them with, the social workers at Children's or wherever, and we can actually get them insured and get them the coverage they need. And if we can't, we still find a way to do the surgery. So anyway, I'm really happy to be here. I love being here. We're in the community. Call me. If any of y'all want my cell phone, you can have it. And that's it. So.